We're back. I'm back. But because I'm back, therefore you're back. Boy, it is good to be back. Talking about the medical industry today. The incentives within it. These are fun to do. These are fun to research. They're fun to record and put out there. I enjoy doing it. Hopefully you enjoy watching it. Or someday you do. These are always tough because it's easy when you're researching these to just do a summary. I mean, it's the classic college paper problem. You turn in your draft and they're like, you just gave me a summary. I don't want a summary. It's easy to find myself in that system while researching these, but I got this one down. We're doing incentives. I'm not giving you a summary today. I'm tying it back to those incentives. Because if you understand incentives, you understand behavior. You can predict behavior if you know the incentives. Not because people are good or bad, but because they're logical. We act logically. We follow the paths that reward us. And so the tragedy isn't that healthcare is evil. The tragedy is that every actor in the system of healthcare is acting rationally based on misaligned incentives. And so the United States has the most expensive healthcare system in the world. I mean, let's just jump right in. The United States spent an average of $12,500 per capita on healthcare in 2022. This is according to multiple sources, including the World Health Organization. Interestingly, they don't provide any information on that demographic any later than 2022. And to me, this is a red flag. Because it's almost 2026. I mean, we're almost 3 years post 2022. And every country has this issue. There's a bit of a buffer period at the end of the year where all of these sources are collecting data, putting it together before they post it out to the public. Because one source can't do it all, so they spread it out. And at the end of the year, they collect it and then post it. It's been over 2 years. We don't even have the 2023 data on this demographic. So to me, that's a red flag. But why is it the most expensive healthcare system in the world? And why does it so often fail to produce better health? Because it's the most expensive healthcare system in the world, and we're like the most unhealthy country in the world. And this is because the incentives within the system are rewarding treatment over health. People act rationally based on these incentives for treatment rather than the incentives for health. There's a big difference, and I'll get into this further. The purpose of incentive, the incentive that doctors and physicians enter the medical field with, the incentive to do the right thing, if you remember, that's the purpose of incentive. It gives you purpose. It's the scenario where you find the wallet and you return it. You're not gaining anything from it except the good feeling to do the right thing. The purposive incentive, they're losing. And they're losing to the material incentive, which is money. Anything that reflects money, that has a amount of money that you can easily see. Even the wallet, you can see that wallet is worth $60. It's not cash, but it's worth. And so the system that was built to heal people has evolved into a system that's profiting from us being sick, quite literally. And that's a big flaw. And so why is it the most expensive? Well, it's the most expensive for many reasons, but one of the reasons is that the way that the price is set is very inefficient. The way that the prices are set is very inefficient. In a free market, prices are set using supply, demand, and competition. There's very, very little to no government action that's taken. Sellers are competing to sell products, and buyers are competing to purchase them. So naturally, prices reach an equilibrium point where the quantity that's demanded by those customers is equal to the quantity that's supplied by the sellers. And an example of this would be, you're in a town and there's 2 coffee shops. They're both selling coffees for $8. Well, a third coffee shop enters the equation. They move just down the street and they're selling coffees for $6. $2 less than those other 2 shops. Well, what you'd see is all the customers are going to gravitate to that $6 shop. They're saving $2 on every coffee. And so what that forces those other 2 shops to do is either lower the price to $6 or go out of business. Because they have a disadvantage. They're selling for $2 more. So the free market forces them to push the prices down so they can still compete. They're not competing to sell if no one's buying their coffees. And so these prices go down and go down until you can't quite undercut anymore. If everyone's selling for $4 and you sell your coffee for $3, now you're losing money. You can't quite go that low. So you have to settle at the $4. That's the lowest you can go. That's how prices are set in the free market. And of course, there's some scenarios where, bigger businesses that can afford to lose money for a year or two will undercut the businesses and just lose money and tank and just lose money on every single sale. $2 coffees when they're $3 to make. But then the smaller companies that can't afford to do that go out of business, they go bankrupt, they lose because they're being outcompeted. And then that bigger business that could afford to lose money for all those years just raises the prices right back up. When those smaller companies go out of business, they go bankrupt. Now we're the only company that's here. There's some scenarios like that, but that's pretty crooked. But that's how prices are set in the free market. Supply, competition, and demand. Well, in Medicare, they don't use this system. And it makes sense. You can't make these medications in your basement and sell them and compete. You can't enter the market. It's not perfect competition. And so they don't use the system. They don't let the free market decide physicians' fees. They use an administered pricing system. And so the problem with this is that in order to set an efficient price, you have to know the marginal cost of production, the cost of providing one more unit of service. Think if you're making 1,000 Pop-Tarts, how much money would it take for you to make one more Pop-Tart? 1,001. How much would that last Pop-Tart cost to make? That is the marginal cost of production. And so that number is very important. But if you don't know that number, you can't set an efficient price. And so the people who are setting the prices don't know this number. In the system, the Centers for Medicare and Medicaid, the CMS, these are the people who make the decisions and to set the prices, to set the physician fees, the CMS. These people don't know this number. They don't know how much it takes to make one extra Pop-Tart, to give one extra shot, to, weigh one extra patient. They don't know this. So they rely on the American Medical Association, and this is a mouthful. They rely on the American Medical Association's Specialty Society Relative Value Update Committee, or the RUC for short, because nobody's saying all that. And this is a panel of physicians. So the CMS, the people who set the prices, rely on a panel of doctors and physicians to report their own true costs through surveys. And so you essentially have a system where doctors and physicians are reporting their own cost data. They're reporting their own data of how much it costed them to give that shot, how much it costed them to weigh that patient, and it's affecting how the prices for those things are set. And then affects their pay. And no direct penalties are administered, either because it's so difficult to identify if errors were made, or, it just goes under the radar. Most of the time the errors are made, it goes undetected. And so imagine that you get to tell your boss how much money your time is worth. And I'm not saying that doctors are lying, that they're evil, that they're scheming in the background. Although, again, there's always one person probably that is. It's that they're rationally optimizing the system that pays them. And this is a small population. It's a panel, remember. So not every single doctor is reporting this data. It's a panel of them. But sometimes that's worse. And so they have the ability to rationally optimize the system that pays them. The system that they went hundreds of thousands of dollars into debt for. The system that they spent 8 years in college for. The system that, medical school is tough. So they're rationally optimizing that system. They went through hell to get here. Now they have the opportunity to throw themselves a bone, And if we zoom out, you start to see a pattern. And it's not just the doctors and the CMS. Every single actor in the system is doing exactly what the incentives are telling them to do. And health is not included. There was a study done by Rachel Reed about physicians. It was a mixed method study of 31 physician organizations, and they found that volume was the main component of primary care and specialist compensation. So when these people are compensated, the main way they're compensated, is based on volume. 83.9%, 93.3%. And most primary care and specialist compensation arrangements do include performance-based incentives, incentives based on how well you did, but they averaged less than 10% of the compensation. So they're being compensated way more based on how much they do, the physicians, and way less based on how well they actually did. Hospitals. Hospitals have huge fixed costs. The infrastructure, the staff, the technology. Once a bed or an MRI machine is built, it has to stay busy in order to pay it off. That equipment is, very, very expensive. This means that even if demand drops, people aren't using those beds as much, hospitals are incentivized to keep the utilization high, to keep those beds full all day, every day. And it's rational. It's rational financially, but it's irrational from a health standpoint. You don't want those beds to be filled. You want them to be empty every day. You want people to be healthy. And I'm not saying that these hospitals are going out and running over people on the sidewalk, breaking their bones so that we can fill these beds. Although, again, I'm sure there's one. But it's just that the incentives are there. Pharma, the business model thrives on long-term customers, long-term medicating people, people who rely on drugs to manage symptoms for life. They made $1.5 trillion in revenue in 2023, most of it from medications that manage these illnesses instead of cure them, heal them. Insurance companies aren't paid to make people healthier. They're paid to manage risk and control their payouts. In other words, their incentive is not to help you use your care effectively. It's to make sure you use as little care as possible. That's how they make money. And then there's us. We have been taught to consume health like a product rather than to live it as a practice. When you're sick, you want to go to the doctor, you want him to give you a pill. You want this pill to fix it. You got a stomach ache, this is going to make that go away. You got a migraine, this is going to make that go away. You're really low energy, you can't sleep. Give me something I can take which will fix that. I don't want to have to worry about it and live a different lifestyle. That's how we've learned. We've learned to consume health. And so you can see the pattern, to make a long story short. Doctors optimize for volume. Hospitals optimize for volume, keeping the beds full. Insurers optimize for risk. Patients optimize for convenience. And the reason that these systems work so well is because they mirror us. We crave the easy fixes. We want health without friction. So the system isn't fighting for us. It's almost fighting against us, and it's profiting from it. And nowhere in the equation is health the thing that we're fighting for. Doctors are optimizing, again, for volume. Hospitals, volume. Insurers, for risk. We're optimizing for convenience. Health isn't in the equation. So it's rational people and irrational systems. Health, of course, is kind of in the equation. That's why we're going there. But that's not what we're optimizing for. And another one of the most important pieces is that the medical industry runs on a fee-for-service system. And a fee-for-service system is where doctors and other healthcare providers are paid, they're reimbursed individually for each service or product that they provide. It's how most doctors get paid. And so if you go to the emergency room, you're charged for all of the parts of your stay on top of a flat rate. You're paying separately for the IV drugs, the IV pushes, the scans, the tests. Everything is separate. And so as a result, tests or solutions might be given that aren't necessary, yet you're paying for them. Because if they don't do the test and they miss something, then they risk being sued. And within this system, the fee-for-service system, there's two main problems that you can separate it all into. The first problem is that the incentives cause inefficiency. Some people get too much care. Some people get too little care. Some people just get the wrong care. And the second problem is that the fee-for-service system drives up the costs. And so within these two questions, the first question answers, why is health so bad? The incentives cause inefficiency. And the second problem, fee-for-service system drives up costs, that explains why it's so expensive, the two main issues. And so the first problem is the inefficiency. we start off with too much care. Now, too much care is the unnecessary use of medical services where the potential for harm to a patient outweighs the potential for benefit. Think a lung transplant. You may live for 8 years normally, but if you get the lung transplant, maybe your life expectancy is only 5. And maybe you are old and you're not going to live, or young rather, and so there's no reason to get that lung transplant. You might as well live out those 8 years instead of getting this crazy, really invasive surgery and then living 5. The cons far outweigh the pros. And physicians report that 20% of medical care is unnecessary, including 22% of prescribed medication, 25% of tests, 11% of procedures, and several articles reflected these numbers. It wasn't just one source that I found that was like, cool, I'll go with that. 20% is unnecessary. No. Several sources were reflecting these same numbers. And so experts estimate that around 1/3 of all U.S. care spending provides no care to the patient or even hurts the patient. 1/3. Why? Well, if you remember, the main thing that incentives do is they shape your behavior. That's the whole idea. And so over-treatment isn't random. It's a logical result of the system's reward structure. And I keep bringing this up because it's important. We think logically. The system is bad because we're all idiots. No. We think logically. We actually optimize. We create faster cars that run on less gas. They've got better brakes, better jets that can fly higher, and phones that text quicker or take better pictures, microphones that sound better. We optimize everything. Medication you can take that makes you live longer, shoes that help you run faster. We optimize everything. That's what we do. We make new stuff. We optimize. But if the system is set up incorrectly, we will optimize for the wrong thing. And that's what's happening. The medical industry is, in fact, trying to do both. It's trying to make people healthy and be a profitable business. Therefore, it's not actually optimizing for either thing. If it had to lean one way, it's optimizing the making money piece. But because it's trying to do both, it's not optimizing for either. But under the current incentives, when doctors make more by doing more, as a doctor, if you make more money by weighing more patients, shoving patients in, getting more people in your office day in, day out, making the appointments quick, weigh him, give him this, give him that, test him for this. If you make more by doing more, the rational thing to do is more. It's rational. And then add in the malpractice lawsuits, because when asked why they ordered this care, knowing it was unnecessary, the most common reason, 85% of the time, was the fear of being sued for malpractice. And so there's a positive reward-based incentive, and there's a negative avoidance-based incentive. There's a push and a pull. One has the motivation to gain, one has the motivation to avoid, to lose your recognition, your notoriety. And so the purpose of incentive, to do the right thing, to do what's good, to return the wallet, it cannot possibly beat out these current incentives. And that is why the healthcare system is the most expensive and yet continues to fail to provide results. It can't beat that out. There's a push and a pull. And you think that you wanting to do the right thing, to do good, to heal people is going to beat that? It's not. And that's what we're seeing. Then I'll move on to too little care, which is the failure to provide necessary and effective health treatments, leading to poor health outcomes. That was just too much care. Too little care. The main barrier is cost. And I'm going to give you some stats, and then I'll explain. 2023, 38% of U.S. adults reported delaying or skipping medical care because of the cost. It was the highest in 22 years. That's from Gallup. That's the source. 25% of adults said that they or a family member skipped treatment for a serious condition because of cost. Gallup. Prescription drugs. 20 to 25% of Americans skip filling prescriptions because they can't afford them. This is KFF. And medical debt. Roughly 100 million Americans, 41% of adults, carry some form of medical debt. That is also KFF Health News. And here I pulled from two different sources. And it's important because Gallup gets their data through self-reported surveys. And surveys are great at some things. Surveys are great at telling public opinion, at telling what people think, how they view the system, what people are experiencing. But surveys also carry very large biases, response bias, sampling bias. The idea that the type of person who would respond to a survey is different than the type of person who wouldn't respond to a survey. And so there's a bias there. The answers might be different because that's a population that's separate from this population. Would respond versus wouldn't respond. There's all sorts of biases with surveys, but they're really good at measuring public opinion. KFF, on the other hand, is not survey-based. They dig into insurance coverage numbers, the government data sets, the Medicare and Medicaid records. They crunch the hard data. So when you put these two together, you get both sides. You get what people are feeling, how they're experiencing the system, and then the cold hard data. And it's important to put these together because you can get the whole picture. And so I keep bringing it back to rational thinking. And so we know that physicians act rationally based on their reward and their punishment structures, that push and the pull. They're acting rationally. Well, patients act rationally too. It's not just the physicians. And when the system forces patients to pay thousands before insurance kicks in, those high deductibles, you create a financial disincentive to seek care. The system built to make care accessible, insurance, accidentally rewards avoidance. And I'll put the money where my mouth is a little bit. Why is cost such a barrier? I just mentioned the high deductibles. A deductible is the amount of money that you have to pay out of your own pocket before insurance kicks in, before they help. And it resets at the end of the year. But the average deductible for employer coverage is now over $1,700. This is from the KFF, that cold hard data. And so deductible prices have gotten so high that having insurance doesn't feel all that different from not having it until something catastrophic happens. When you're going to this primary care, you've got a cold, you don't feel good, something's up, you go to the doctor for a short little checkup, you're paying for that because you haven't reached your deductible, your $1,700. You haven't reached the level where insurance is going to help. So you're disincentivized to do those small checkups. You figure it out. Your knee hurts, but you're good. You don't go. And so for families, this often means skipping the primary care until the emergency happens, until you get in a car accident, and bam, it's going to be $50,000. Now insurance will help. But for those small checkups, it's not helping at all. And so providers are incentivized to do too much, and patients are incentivized to do too little. The incentives are incredibly misaligned. And so the system that is supposed to make care more accessible, insurance, the system that was designed to help you, the high deductibles are discouraging you from seeking care. It's not doing that. It's making you feel like you don't even have insurance until something catastrophic happens. It's not helping with the day-to-day. And so insurance is protection against disaster rather than everyday help. Disaster doesn't happen very often, so insurance companies are making so much money. And then there's scenarios, which is crazy, where even when disaster does happen, they just go, no thanks. They deny your treatment. I mean, there's this example of Ben Askren. He's a famous fighter. He just recently needed a double lung transplant. Whoa, it's a big surgery. You or I, he's famous, he's got money. You or I, especially, could not afford that. That's why I pay my insurance. Good. My insurance is going to help. No. If you look, you can literally look this up. Ben Askren's insurance denied his claim for the double lung transplant. They denied it. Jake Paul had to, I think he created a GoFundMe. He got this treatment, but the insurance didn't cover it. People rallied together, raised money to get it paid for. People aren't going to raise money for me to get a double lung transplant. People don't know who I am. People don't know who you are. Maybe. I don't know. Maybe they do. But the fact that you can pay the insurance every month and they can still deny it, they're making a crap ton of money. I mean, too little care. Now we get into wrong care. This is where the delivery of care it's ineffective. It's inappropriate. It's misaligned with what the patient actually needs. You're getting the wrong care. And wrong care is different from the previous examples. It isn't just over-treatment or under-treatment. It's care that's optimized for short-term intervention rather than long-term healing. There it is again, optimized for the wrong thing. A bit of a theme here. And so there's two types of illnesses that they treat in healthcare. One which they're really, really, really good at, and one which they're not. And these two types of illnesses are acute illnesses, acute condition, and chronic illness. Both disrupt the life of the patient, but they do so in different ways. And thus they're treated differently as well. An acute illness. An acute illness is an illness that develops suddenly. It lasts for a short amount of time, and it often has a clear cause, clear symptoms, and usually clear treatment, cure. Examples of this are a broken bone, hives, an allergic reaction, the common cold, a migraine, things that happen suddenly, clear reason usually that it happened, clear fix. They're really, really good at this. The medical field actually thrives. If you break your bone, they've learned how to take care of that like nobody. I mean, they're really, really good at stuff like that. The technology has gotten good. You can trust your local resources on these acute illnesses. However, it seems that those same resources are falling behind on the chronic illness front. Chronic illnesses are an illness that develops over a long period of time. It persists for months, for years, and it often cannot be fully cured, only treated. Examples of these are diabetes, heart disease, obesity, depression, Alzheimer's. These are chronic illnesses. And when I say that people are getting wrong care, what I really mean is that people are getting care which is optimized for these acute problems, what they're really good at, when they should be treated chronically. Casey Means wrote a really good book about this called Good Energy, where they discuss mainly chronic illness and how the medical field is struggling with this. And the book talks about, metabolic health. A patient with pre-diabetes might get medication to help with the symptoms, but not the nutrition counseling or the lifestyle support, because those aren't billable or well reimbursed. A scenario where someone has bad metabolic health, they need to be treated chronically, but they're treated acutely. Mental health, a doctor prescribes antidepressants that fix the symptoms, acute symptom management, but they don't address the chronic stress, the diet, the sleep. They're putting a Band-Aid on it instead of curing the long-term problem. Autoimmune issues, patients bounce between specialists who treat each of their domains, their gut, their skin, their joints, and nobody looks at the underlying systematic inflammation. These are all examples of rational care under irrational incentives. We've built an entire system that's really, really, really good at saving your life. I mean, if you got in a 60 mile an hour car crash 100 years ago, which you wouldn't do, but if you did, you're probably dead. But we're really good, and you might still be dead now, but we're much, much, much better at saving your life now in those scenarios than we were before, but not necessarily at keeping you alive and well, those chronic illnesses. And then there's another piece to the puzzle, which is that medicine has gotten incredibly specialized. Casey Means also talks about this. Healthcare splits the body into different parts instead of treating it like a cohesive system. And it makes sense. There's so many details in the medical industry that you're forced to do this. One person cannot possibly know every single thing. You have to split it up into specialists. I mean, anybody who's studying the medical field, going to college for it, knows even within your specialty, there's so much to know. It's overwhelming. It's terrible. You're trying to learn everything and remember it, and it's awful. Well, if you had to do that for this part of the brain and this part of the toe and this part of the neck and you had to connect, it's impossible. You can't possibly know all of that stuff. So they have to specialize it. Makes sense. But as a result, cause, effect, those specialists stay right in their lane. That's what they know, that's what they're good at, they stay right there. And they only look at their piece rather than how their piece affects the puzzle as a whole. And an example, because these are important. Mark, 45 years old, he's exhausted all the time. He's gained 30 pounds in the past few years, which is unusual for him. He can't sleep very well, he's got mood swings, his digestion just feels off, he's got acne breakouts. Well, he goes to his primary care physician, and the labs come back fine, Everything looks good, but he insists something's wrong. I know this isn't right. He's smart. We know our bodies. So the primary care physician reports him to specialists for all of those issues. The dermatologist gives him cream for his acne. The gastroenterologist prescribes antacids for his digestion. The endocrinologist says the blood sugar's a little high. You're not diabetic yet, but you still qualify for metformin. The psychiatrist puts him on an antidepressant. The sleep specialist gives him a CPAP machine. By the end of this, Mark's on 3 different meds. He's got a skin cream, a CPAP machine, and a bunch of bills. And not one of them asked what's causing this. Not one of those specialists compared notes. They didn't look at the fact that Mark has been healthy for 40 years. And all of a sudden, at the same time, he's got acne breakouts and his digestion's off and he can't sleep, he's got mood swings. All these things are happening at the same time. They're not comparing notes. They're fixing their puzzle piece. And they're feeling really good about it, too. They're like, wow, that guy came in here, he had acne, I gave him the cream, his acne's gone. You feel good. They're probably feeling fulfilled about that. I gave him an antidepressant, his mood's going to be better now. Yay, I did a good job. But they're not solving the issue. They're putting a Band-Aid on it. And each doctor fixed their slice, but no one looked at it as a whole. The chronic inflammation, the insulin-resistant problems, the poor mitochondrial health, his nutrition deficiencies, his stress levels, his sleep. This is what I mean by he was treated but not healed. Treatment over health, what I talked about in the very beginning. That's the big issue. And that is what wrong care looks like. And so when you zoom out, it's so wild how everything fits together. Hospitals, insurers, pharma companies, doctors, they're all just responding to the incentives around them. No one here is crazy. No one's trying to sabotage healthcare. Everyone's just following those incentives in front of them. The incentives that are shaping their behavior. Doctors are rewarded for doing more. Hospitals are rewarded for filling more beds. Pharma is rewarded for keeping patients on long-term medication. They're making a crap ton of money. If you're going to pay me every month for 40 years, that's a good system for them. Insurers are rewarded avoiding payouts, saying I'm not going to pay for your double lung transplant. Having a high deductible so that they're not helping with the day-to-day care. It makes sense for them financially, but not for us health-wise. I think that if deductibles were a lot lower or not existent at all, which I'm sure that there's a reason you can't do that, we would be way, way more likely to go to our primary care physicians, to go to the doctors for checkups all the time when things just feel off. Even when you feel healthy, going to check up and getting a ground of what health looks like in your body, doing all your tests, we'd be way more likely to do things like that. But the incentives are to avoid care. We have to spend $1,700 every year before we can even get the care and the insurance to cover the care. And then we're rewarded for convenience because of that. We want the pill. We want this to fix. Our acne's here. We want to just shove something on it in the morning and have it go away. We don't want to have to start eating whole foods and go for walks. And it's not even that we don't want to. It's that we don't know we have to do that. Some people really don't. We're not being taught that. We're being taught, you need this stuff for your face. Oh, your digestion, you just got bad digestion. You need to take this medicine. And it's all rational behavior inside irrational systems. We're optimizing for the wrong thing. And the thing that's ironic is that the system was built to help us. I mean, insurance was made to help us pay for care. Fee-for-service started as a way to compensate doctors for their work. Look at all the stuff you're doing that's going unnoticed. Sorry, we'll reimburse you for everything that you do. That shot, we'll pay you for it. This, we'll pay you for this. Insurance was designed, well, I already said that. Specialization was meant to bring expertise. We want people who are really, really good at working on the brain. We don't want someone who's decent at everything. It's meant to bring expertise. Perfect. But as a result, you're not comparing notes. Each part makes sense on its own until it doesn't. Until you look at the big picture and realize that it doesn't make sense, that it's actually not working. And the worst thing is that the metrics the numbers look very productive. I mean, the doctors are like, look at how many people came in the office today. Look at how many people I helped today. Look at how much money we're spending on healthcare. Just look at all the data. It looks good, but the outcomes don't. We spend more money than any country in the world on healthcare, and yet Americans are sicker. We're more stressed. We're more infertile. We have lower energy. We're getting worse sleep. We're dying younger than ever. And that's not true. We're not dying. We're actually living longer, but we're not living healthy lives. And it's not because we don't care about health, but because the incentives are rewarding treatment and they're not rewarding prevention. They're not rewarding health. And so we have to change our values. We have to change what we value. Because the good thing about incentives is that they shape behavior. Hopefully that's not getting annoying. I'm going to say that a lot more. The incentives are shaping our behavior. But so if we change what's important to us, we no longer value convenience at the utmost thing. It's not the incentive that's winning. This goes back to the incentive Darwinism idea, the idea that the incentive that is the most powerful and the most salient for you will win within you. We all act differently to incentives, but the one that's the most powerful wins. And so convenience being the most powerful, that's the one that's going to win. But if we change our values, we change what's important to us, now health is the most important thing to us. Our value will change the incentives. And then the incentives will change the behavior. If we decide that health is the most important thing to us, the market has to follow us. We're the customers. So then these systems will have to change their behavior. We have the power, it's just we have to change our values. And it's a difficult thing to do, but that's the good thing about this, is that it's not just that like, oh, we're actually just screwed. No. Incentives shape behavior. So if we change those incentives, we change what's important to us, we can change the behavior, and then we can change the system. We can change the result. So that's the hopeful piece. I just think it's important that we take a look at that and we figure out what is important to us, and we at least just bring more discussion to this idea. Because people and systems get the blame, and in some scenarios that's valid, but in some scenarios it's not. And on a wide system base, these issues are stemming from the incentives. And so I think we got to take a look at this. We got to change our values. We got to figure out what's important to us, which is health, living long, happy, healthy lives. And then the market will follow. The system will follow. And it's so important that we get these incentives. Sorry, I'm rambling at this point. But it's so important that we figure out incentives and that we master incentives, because AI, the only thing that artificial intelligence is going to have to run on is incentives. That's it. And so if we don't master incentives by the time that we're getting to, super natural artificial intelligence, then we're going to be screwed, because the only thing that's going to have to run on is incentives, and it's going to do a way better job at tasks than we will be able to. It's going to far exceed our ability. And so if we don't master those incentives, get it just right, figure out how to get that AI perfectly incentivized for us, it's going to optimize for something incorrectly. I mean, think about it like this. There were scenarios where early ChatGPT, you talk to it and you learned that, I don't know. There were some examples where, it's bad to misgender someone. Sure. And so what's a way to avoid misgendering anyone ever again is to kill all humans. It's a small example, and maybe I didn't explain it that well, but if something is made to optimize, and say bullying happens in humans, maybe this is a better example. If the AI wants to eliminate all bullying forever, kill all humans, get rid of them. That'll never happen again. There are no more bullying. And that's an extreme example, but it's one that can actually put in picture what's possible. It has to be perfectly aligned. The incentives have to be perfect with AI, or it's not gonna work in our favor at all. It's going to be bad. And maybe I'll do an episode on that, because information's coming out every day on that topic. But I don't know. Next time I think I want to get more into the psychology piece. I think that there's a lot of incentives within psychology. Behavioral economics is really cool to me. I've always thought, like, if you know economics, if you can understand economics, you can understand everything. And I'm not an expert in economics by any means. But simple ideas that you know really well, you can see in life. And so behavioral economics is basically exactly that. And it ties in psychology. So that's interesting to me. So I'll probably do an episode on that. Maybe the incentives of fear. Something cool. But I'm going to take a break from these huge systems for a while. I'm going to dig into the psychology. But thank you guys for watching. Thanks for listening. If you stayed till the end of the rant, thank you very much. And I'll see you next time. This is fun. This is cool. Hopefully I'm doing a good job presenting this.